tell us, when do we need salvage ADR?
Okay, this works. Good afternoon, Dr. Werner, Dr. Trehan. It's truly an honor to be talking in front of you guys. Thanks for inviting me to ijcto. And so we're going to talk about salvage ADR in about 8 minutes, I guess. So I wasn't exactly sure about what I was going to talk about when I got this topic, but I thought I would broadly divide it into two categories. One is wire-based ADR, which for all practical purposes essentially is salvage ADR in today's day and age. And secondly, device-based ADR when primary wiring doesn't work. So looking at hybrid, in essence, what we really want to talk about is this. When ADR has failed, sometimes you got to just use some kind of a wire-based strategy as a technique to get back into the true lumen. And there are other situations where you might want to use it outside of the hybrid algorithm. So when we talk about wire-based ADR, what are we talking about? We're talking about star, mini star, last, whatever you want to call it. And like I said, by definition, these are all salvage ADRs. Let's just talk about, and I do want to take a minute to tell you that wire-based reentry is very, very different than parallel wire. And the key difference is that in parallel wire, when you use the second wire to get back into the true lumen, you're actually entering at the distal cap, not beyond the distal cap. I know it sounds like it's just a theoretical difference, but they are really different. So star essentially is you're just trying to get into the subintimal space and taking a knuckle. Contrast is when you're just using the hydraulic dissection that the contrast can help achieve to create a dissection plane, and then you're going to follow it up with a knuckle. And mini star and last, which are the other two strategies that can be used. And again, this is where you penetrate the CTO body, get in with a XT or a FC, XTR, a Mongo, fighter, any wire that knuckles fairly easy, get into the false lumen and push it really hard, and then it accidentally gets into the true lumen. Last is where you use a wire-based strategy to get in. Instead of knuckling, what you're doing is use a penetrative wire, microcatheter, stick in to the true lumen. I don't know why it took me back there. Okay, guys can, okay, there we go, good. And then you use a polymer jacketed wire to re-enter into the true lumen. Am I pressing the wrong thing or something? Okay. Can I just hear one touch, not two? Okay, good. So any wire can be knuckled, but the wires that work really well are, like I said, XT, fighters, XTR, FC, any wire that knuckles easy. You could even do it at the Pilot 200 if you are really in a pinch. Again, just to reiterate, how do you perform it? You penetrate the proximal cap with any kind of a penetrative wire. Once you're in, get your microcatheter nudged into the CTO body itself, take a wire that knuckles fairly easy, push it really hard, and then re-entry just happens at wherever it happens. And you want to confirm that you're in the true lumen with a contralateral injection. And when do we do it? When there is no option. Essentially, that's what it comes down to. When you have a long CTO, you don't have a retrograde option. You've tried ADR and it has failed. You've tried parallel wire, nothing works. IVUS guided you've seen some really good talks on all these things. But sometimes, guess what? Nothing works. And you're just doing it as salvage. And I said preferably, but I think really we should just use it as a bailout technique. Why? Well, I mean, you're going to be like, I'm already in the true lumen. Why don't I just stent and get out? Because although you have good success rate initially, and you've successfully recanalized the CTO, it's uncontrolled. You have no idea where you've re-entered. Now, if at all you're considering stenting it, I would strongly urge that you do IVUS, confirm, and figure out where you've re-entered into the true lumen before you stent it. And if there are side branches that are important, most likely you will lose them. And if you have stented right without doing any of this stuff, you're probably the patient's probably going to come back with restenosis. And there's some data to suggest that just waiting and giving it a couple of weeks and then bringing them back, you can stent much more judiciously later. So again, this is a patient with a CTO of the circ. The case details actually don't matter particularly, but that's the circ. That's the right. So not great retrograde options. So initial attempt to do an IVUS guided puncture, and then you essentially are doing what, one of the things that was not talked about, I think, was base, where you essentially create a dissection in the just proximal to the CTO proximal cap with a 1-to-1 NC balloon, take a microcatheter, take a knuckle, get into the subintimal space, and then push it really hard. And you're in the true lumen. Balloon it. You're now just checking to see what's, and then you see that there's another branch of the OM that's there. Microcatheter, get, again, you don't care about where you are as long as you're in the architecture. Take an XT, push, push, push. It gets into the true lumen at some point. Balloon, balloon. This is what it looks like. You'd be really tempted to stent it, but don't. Walk away. 6 weeks later, this is what it looks like. Got 6 more minutes. Okay. So easily wired both. Balloon. There's an IVUS which essentially shows that distally was true, limited subintimal. So I'm going to skip it in the interest of time. Balloon, balloon, stent. See, the other branch is not doing so well, but you have a wire. That's the final result. Anyways, this is just one case, again, that doesn't make what you need to do, but about a year or two ago, actually just a year ago when it was published, they did show that waiting and stenting later, you get better long-term outcomes, at least in a small cohort of patients. But the long and short of it is don't stent right away unless you have nothing else to lose. This is just one case showing LAS. It's from a few years ago. And all I really want you to pay attention to is just the tip of the wire. The wire, oftentimes it uses a penetrative wire. You could use the Hornet 14 or a CP12, which is what we used to use. And the key difference is instead of the typical CTO bend, you put a 2 to 3 millimeter bend, 45. So it's more of a re-entry bend that you want to use. And again, it works in some cases. So what are we talking about when we talk about wire-based re-entry strategies? Really resist the urge to stent. Deferred stenting after STAR is much better. There's a term that I think we like to come up with terms for anytime we do anything crazy. It's called subintimal plaque modification or SPAM. But in any case, the idea is don't stent after that. So preferably you want to use these as bailout techniques, whether you use mini-STAR or whether you use LAST. When you want to stent, I would say, again, really consider stage stenting, because you will end up stenting more than you need to if you stent at the time of the index procedure. And if you want to have a branch that you want to rescue, use a dual lumen catheter and try to get in. If cost is an issue, yes, you can go back in with the same microcatheter because you really just want to be in the architecture of the vessel. And if you do have a bifurcation and you still want to stent it, like I said, imaging I think is critical, important. You really don't want to do it otherwise. The reason not to stent it, like I said, is like you don't have good long-term outcomes. So I'm going to skip that. I have 3 more minutes. So what is device-based salvage ADR? Or really, this is a term that I just kind of made up, I think, is when you use ADR as a secondary strategy. Outside of the West, I think most people still use a lot of wire-based strategy. And the key is like, okay, when do you switch from wire-based strategies to a device-based re-entry strategy? So, I mean, I guess it is salvage in a way. I think many times the reason ADR fails in many parts of the world is because it's done very late. One of the biggest reasons why ADR fails is because of hematoma. So the more you play in the subintimal space, the bigger the subintimal space, thereby reducing the chance of successful re-entry when you take in your Stingray. If there's ambiguity, again, I think a lot of us would recommend you knuckle, and I'll just show you a case where we had to do that. So let's look at some cases. This is a case from actually many years ago. So you have an unambiguous proximal cap, it's an LAD, short lesion, distal vessel's okay, collaterals are actually okay. So the plan was to try and wire it, and if that didn't work, we'll switch to ADR. If that didn't work, go retrograde. Now, I have Dr. Werner sitting on the panel. This could have been a great case for parallel wires, so I'm going to just say that up front. hey guys, how do I go back? I need to go back one slide. Can go back? Back? Yep, next slide please. Thank you. So this essentially just shows you, I mean, the wire just went like really fast, but it was subintimal. Now you could have been more patient, could have done paddle wire, no disputing that. Now one other thing that you could do is you're right there. Take your microcatheter, exchange this, your regular wire for Miracle, take your Stingray balloon catheter, and then the idea is that you can just achieve targeted reentry. This is the right position for reentry. You got to move the II around till you get one line and two dots. Okay, I have a minute and 30 seconds. And then essentially, once you do reentry, you want to confirm that you're in the true lumen with a contralateral injection, and the rest is just plasty. And here's another case. Actually, this was from 2 years ago from Korea. Again, a case where, can you go back one slide, please? Just one slide. Okay, good. So ambiguous proximal cap. So I don't really know the length of the lesion. Distal vessels, okay. Collaterals were really iffy. This was a center where they do a lot of retrogrades. So the plan was to try and go retrograde first. I'm sorry about the color. If that didn't work, I was guided antegrade wire escalation. If that didn't work, ADR. And so that's kind of what we're dealing with. There were no contralateral collaterals. So they tried to wire this collateral first, unsuccessfully, then one from the OM, didn't work. Plan was antegrade wire escalation, so an I was guided puncture was done successfully, and you guys have just heard a great talk on it. However, unable to wire the true lumen, and by that time, with whatever manipulation, there was no visualization of the distal vessel. And so really, in fact, Mars was like, let's just stop. I don't think this is going to work. But they were like, all right, we got to try. So we did something that can be done, which is, we knew we were in the architecture, so just did a knuckle. I didn't want to take a penetrative wire followed by the crossbars here. And here's the Stingray balloon coming over a Miracle 12 wire. So you just saw the Stingray balloon there. Okay, I'm out of time, so I'll just keep. So that's the Stingray right projection. But the key point I want to make is that you don't see the LAD here at all. So I have no idea if the LAD is to the left of the balloon or to the right of the balloon. So, and this was despite trying to aspirate, doing all the maneuvers that you can do to improve visualization, nothing worked. So what you can do in this situation is to stick both ends of the Stingray balloon and then just go by feel with a polymer jacketed wire. And so it turned out that it was the one on the left. And so once you're there, but this is kind of a feel thing. So once you're in the true lumen, it goes. It's it just sailed into the distal lumen, and we were able to achieve successful revascularization. So in conclusion, when you use device-based ADR, it's kind of different than wire-based ADR, although I did put them into this basket of salvage ADR. It's much more controlled and precise. There are, at least on 1 year follow-up, there don't seem to be any major adverse trends noted when you do subintimal reentry. Now that is when you have controlled ADR. If you have failed to achieve targeted reentry, don't stent, just walk away. That's pretty much it. Thank you very much.
Thank you, Arun. I think this is a very, very difficult topic, and you were asked to describe something which most of us feel it is very, very unconventional. We are not most of the time very sure about as to where the knuckle will go, as you have already said it. But one word of caution, as you're advancing your knuckle, always keep a watch. If you find that knuckle is widening, just stop there, because that means you may be inviting a trouble.
And that's a great point that Dr. Trehan just mentioned. When a knuckle explodes, it often is because you have already exited the architecture. Many times what has happened is that you have, you try to penetrate with the penetrative wire in a microcatheter, your microcatheter has already followed, you've exited. So when your knuckle explodes, you got to be super careful, and you've probably created a perf.
Yeah.
So yeah, that's something
and
that
much
you need to be
before that, what
cognizant
you
of.
will find is as the knuckle is forming, the tip stays stuck somewhere. Tip is stuck, and as you are advancing the body, if the tip also moves, then usually the knuckle doesn't widen. But if the tip is stuck somewhere and then you are advancing the wire, there is a chance that the knuckle can widen and it can explode out.
I'm sorry for the interruption, Mr. Chairman. We've totally run out of time. Thank you very much to all the speakers and to our chairpersons, Professor Trehan and Professor Werner. There's an important piece of